Welcome. I am Dr. Martin Rutherford. I am a chiropractor since 1979, and I am also a certified functional medicine practitioner, which is the greatest part of my practice today. And I have partnered with Dr. Randall Gates.
I'm a board-certified chiropractic neurologist as well as being a chiropractor.
And these two separate functional disciplines have come together in our office in a fashion that we have been able to develop some pretty consistently successful methodologies for handling chronic pain and chronic conditions in general. But today we're going to talk specifically about peripheral neuropathy. As Dr. Gates reminded me earlier, we have done snippets of information online on every type of peripheral neuropathy that there is, but we have yet to give you a more or less a full presentation that kind of ties it all together with a neat little bow and lets the person watching today get the full spectrum of what peripheral neuropathy is, the complexities of it, why it's not just diabetes, why they say so much of it is idiopathic, meaning they don't know what it is, they being whoever treats it out there. And so that's what we're going to accomplish here in the next 30, 45 minutes, whatever it takes. And so we're going to talk about peripheral neuropathy. And I guess the first thing to do might be to define it. Peripheral neuropathy is?
It's a condition where the nerves start to degenerate, typically down in the feet, spreading up to the knees, then it can go to the hands. You as the patient or a loved one of the patient will notice that they have numbness, tingling, burning sensations, feeling like they're walking on rocks, may have muscle twitching and cramping in the legs, may have some weakness in the legs.
The gentleman has all of that.
And those are kind of the cardinal features of peripheral neuropathy.
And just to define it a little bit more, just because in talks and in consults, people kind of say, what peripheral, this peripheral neuropathy. Peripheral means it's, as Dr. Gates said, it's peripheral. Central would be brain, spinal cord, that would be the central part of your nervous system. This is the peripheral part of your nervous system, the nerves that go out to your organs, the nerves that, but mainly in this case, your hands, your feet, and so any of you who are watching this, mainly we're going to be talking about feet, knees down, hands for the most part. And when we started doing chronic pain, we start out with fibromyalgia, and which we now know that half of people who have fibromyalgia
small fiber neuropathy
have small fiber peripheral neuropathy, which is something that was kind of a good observation and a good thing for us to know. And when we got into this, there was not as much knowledge as there was today relative to the different causes. Where people coming in saying, I have this stuff, and I don't know what it is, but my feet kind of ache, and I went to the doctors. At the time, we had no idea how much peripheral neuropathy was out there. I mean, would you say it's common?
It's very common.
I mean, like, it is unbelievably common.
Mm-hmm.
Is there some statistics?
Absolutely. So basically, 20 million people in the United States have peripheral neuropathy. 1 out of 10 over the age of 65 have peripheral neuropathy.
Which just seemed like more to me.
Well,
I mean, that's still a lot.
1 out of 10 have Parkinson's in the elder population. So if you're talking to your grandparents, they'll say, "Oh, Joe has Parkinson's." Most people in that age range are aware of somebody with Parkinson's. The same thing goes for peripheral neuropathy.
Yeah, and I think people are becoming aware of it. That now that I do the consults, I do the intakes here as far as qualifying patients and determining whether they would be good for our programs. And they're more and more often now they're saying, "Man, I have all kinds. I have this friend that has it. My aunt has it." And I think people are becoming more aware of it. I think a lot of in the beginning people were kind of writing it off to bad feet or old age or things of that nature. And now they're starting to realize that it's and plus, I think we're starting to overcome the idea that it's all diabetes. And maybe we are, maybe we're not, because the gentleman I interviewed yesterday is going to a lot of people, and that's pretty much what they told him. And he said, "Well, I don't have diabetes." I said, "Well, then you have an idiopathic cause," which means
they still diagnose him with idiopathic, even though he had kidney failure.
Yeah. Yeah, he did not. Yes. So we're going to talk briefly about organ failure eventually here, but they did not. No, they did not connect the peripheral neuropathy with the organ failure. So neuropathy is really common, and I guess the next question would be, we kind of morphed into it a little bit. Why are so many people with peripheral neuropathy told nothing can be done to correct their problem? And you want to go with this?
Yeah. So it's a double-edged sword. So with peripheral neuropathy, we always have the nerves that have degenerated or they're dying. Again, out in the extremities, typically starting in the feet, can spread up to the hands. And there's most commonly a metabolic cause to that. By metabolic, we mean it could be ranging from diabetes to vitamin deficiencies, to cancer, to thyroid, to autoimmune disorders. We're going to go through all of that. And in essence, one would think, well, if I get to the underlying cause, let's say I have a vitamin deficiency, if I start taking that vitamin, will that repair the nerves? And frequently is the case that it does not. It may help delay the progression of the neuropathy. It may improve nerve function to a slight degree, but most of the research, and there are a few exceptions, but most of the research designates that basically if you address the underlying cause, it's not going to improve the person's symptoms. Okay. By the flip side of things, people raise the question, well, could we go back in and start stimulating the nerves back to life? Could we kind of put voltage into those nerves? And in doing so, some of the...
so you might know that as electrical stimulation. A lot of people come and go, yeah, I got one of those electrical things. You put the pads on me, and is that... In fact, this gentleman had one yesterday. It wasn't a tense unit, and he put it on his calves. Okay. And it would actually make him feel better.
Okay. Yeah, that's great. Yeah. Some of you may be paying for laser treatments. We hear patients doing that. You know, you're going to get a laser 3 times a week, but then once you stop doing it, your symptoms come back. Same thing with these electrical stimulations. The reason why that is not commonly accepted in neurology and medicine is because it's a short-term fix, so to speak, for your symptoms. It's really not correcting the cause of the problem.
Right.
And so that is why so many of you are told out there, you have neuropathy, nothing can be done about it. Shut up, take your medication.
Because even though they understand that these electrical stimulations and the laser can have a positive effect in reducing the pain, it's also well understood that if you don't take care of what caused it in the first place, it's just temporary. And so I will add to why so many people think nothing can be done out there, because their doctors tell them nothing can be done, partially for this reason. But a big part of it is just simply that there are over 80 different reasons for possible causes. 80, depending on who you're reading, could be 50, it could be 80. There's a lot. There's a lot of causes for peripheral neuropathy. But in the medical community, it's pretty much you either have diabetes, 50% of people have diabetes. If you don't have diabetes, then we don't know what it is. And they do acknowledge some what are called pseudo-neuropathies. In other words, they're not really peripheral neuropathies, but carpal tunnel syndrome, they might call it a peripheral neuropathy because neuropathy means some sort of pathology to your nerve. Something bad is happening to your nerve. So something bad is happening to your nerve, causing your hand to be numbness and tingling. What's happening is it's getting pinched. Sometimes they'll acknowledge a pseudoneuropathy being a low back problem, where you get a pinched nerve in your low back or your spinal cord, or a tiny or a spinal cord that's smaller than it should be. Sometimes you get a pinched nerve in your ankle that'll cause a sharp shooting pain into your feet. And those may be diagnosed as neuropathy by your medical doctor. And we're not bagging medical doctors, okay? We're kind of going to get to that here in a second. We work with medical doctors every day. So, but these are pseudoneuropathies. And the reason I mentioned them along with diabetes is because these are the neuropathy conditions that insurance companies cover. All right, and I mean, this is really the practical aspect of why people are not even going to get to what we're going to talk about, because basically when you go into a medical doctor's office, if you're going in there on insurance, this is what they're allowed to look for. They find one of them. If you got a back problem, if it needs physical therapy, if it needs surgery, if it needs injections, they'll okay that. If you got an ankle problem, they'll do surgery, they'll do laser, whatever they'll do, they'll okay that. But if it's any of the other things we're about to talk about, which is most of what causes peripheral neuropathy, your doctor generally is not going to is not going to even pursue it because it's not in the insurance code that he works by. And then it's another reason why those of you may go from doctor to doctor to doctor hoping for a new solution and keep getting the same thing over and over again. And it's because they're not going to go anywhere with that. Oh, and I forgot to mention chemotherapy. They'll acknowledge that chemotherapy has caused you peripheral neuropathy and tell you that it'll either come back in 2 years or you'll just have to live with it.
Yeah.
Or
We've heard many oncologists say, well, the neuropathy is worse than cancer.
Right.
Oh my God.
These are the reasons why so many people are told that nothing can be done for peripheral neuropathy. And we can tell you a lot can be done for peripheral neuropathy. There are very few cases, and there are cases that can't respond, but for the most part, most cases can be improved, usually substantially. I'm not sure if I could use the word total resolution. I don't know, you know, but close.
But some
close.
cases.
But certainly stopped, reversed, reduced, usually substantially, and then managed from that point on, and for the most part without medications. So why don't we go into that direction?
Okay.
How do you figure out? Okay.
So, and that brings in the merging of our disciplines.
Yes. Okay.
And so functional medicine looks at getting to the cause of the underlying problem. Case in point, if you have heart disease, medical management of that would be, we're going to put you on a blood pressure lowering medication, we're going to put you on a statin medication, so on and so forth. Yeah, aspirin. Whereas the functional medicine approach is, well, let's get to the cause of the problem. That's no denigration to the medical approach. It's just, it's going to be a lot more laborious, and it's going to be a lot more work on your part as the patient than the doctor. And so that's going to involve, okay, maybe you're 40 pounds overweight. Maybe we need to look at why you're overweight. Maybe you have a problem in your gut with bacteria that's causing you to gain weight. Maybe your diet is off. All these different
Maybe you're
things.
overweight, the doctor told you to lose weight, you're trying to lose weight and you can't lose weight, and you need to find out why that is.
And that is just an isolated example, merging with what I do, which is going in and rehabbing the nervous system, electrical stimulation, brain exercise. We're going to talk about the brain relative to neuropathy today. And kind of taking that one step further relative to neuropathy, let's use vitamin deficiency. So let's say you think you have a B12 deficient neuropathy, just like every neuropathy patient out there who doesn't have diabetes.
Everyone comes in and they go, what about B12 and alpha-lipoic acid?
Yeah. And so if you have a B12 deficient neuropathy, we have to say, well, why? Do you have H. pylori in your stomach? Do you know what that is? That's a bacteria in the stomach that can cause you not to absorb B12 well enough because you can't make enough acid. Are you taking Prilosec, a proton pump inhibitor, which is not allowing you to break down your food enough to get B12 out of the steak that you just ate? Do you have a parasite in your intestines? Do you have celiac disease? Do you have Crohn's disease? Do you have ulcerative colitis to where you can't absorb the B12? Do you have pernicious anemia, where basically your immune system is killing the factor that binds to B12? You can see how immediately this is pretty complex. This is just one isolated example of the 80. And
the medical model would be, and again, we're not knocking it, we're just saying the medical model is an acute pain model. It is about medications and it is about surgery. That's what it's about. I don't think anybody would argue with that. B12 is not a medication, but it is. But a lot of patients come in and they do get injectable B12 and feel better. And they go, well, I'm doing the B12 and I feel better. I'm like, well, that's good, but you're going to be doing it for your next 6 lifetimes because you're not getting to what the cause is, that you don't have enough B12 in your system. If you're not a vegetarian, there should not be a problem with you getting B12 unless you have one of the many things that Dr. Gates just enumerated.
Yeah, so once we figure out the cause of your B12 deficiency, then we address that, coupled with me coming in and stimulating the nerves, trying to shock them back to life, which has now been shown in the right setting to regrow nerves, bring more blood flow to nerves, actually decrease pain, tingling, and numbness. And so coupling those two approaches is the impetus for us writing this book, and we've been talking about it for a while. We've had a few distractions, it's okay, but now we're on it. And
by June,
I'm aiming for March for it to be done.
Okay.
June for it to be
I'm
completed.
good with that.
But anyways, we wrote this book because people out there need to know, and there needs to be a real book. Story behind the book.
There is a real book, the neurology book.
Well, that's for clinicians.
This is for
you as the patient. I started writing this book in January of 2013, and I wrote it, and it sucked. and you said so, and a few other people did. Because I just had this idea, well, we need to get a book out, and let's just be like everybody else who wants to get on Oprah. Let's just write the book. And I wrote it, and I did it quickly, and it showed. So we've since gone back. We pulled this apart. I can't tell you how many times we've written most of these chapters. And Dr. Rutherford is working on it with me, as well as we have another editor. And it's going to be a
translating it into English.
I translated it 5 times down to what I think you as a patient out there would understand it as, but sometimes I fall short. And with that, our aim is to have a quality piece of information for you out there as a neuropathy patient to read, so you know you have some data when your neurologist comes to you and says, oh, there's nothing that can be done for peripheral neuropathy. You say, well, what about XYZ? Let's talk about this.
And if you ultimately, if the book achieves its goal, you'll be able to read through the book and kind of sort of go, I think this is me. Or I think these 3 things are what's possible.
Right. And we have tons of cases. So it's called Peripheral Neuropathy Success Stories. So we have cases throughout the entire book to where you can read and say, oh, that's just like me. Oh, I have diabetes. Or, oh, I have celiac disease. Or, oh, I have a B vitamin deficiency. And this person was just like me and they improved. So
for you peripheral neuropathy patients, the first thing to figure out as to how to get better is to find out whether you actually have peripheral neuropathy. We have a lot of patients coming here who have been just glibly told, oh, it's in your feet, and yeah, you have neuropathy. But nobody's, and people who even had nerve conduction velocity tests done and told that they didn't have it. So we've had people come told that they didn't have it, and we've had people told that they have it, who didn't have it. So the first thing is to make sure that you have it. So, and we have developed kind of a pretty comprehensive approach to figuring that out. And maybe would you like to go over that?
Absolutely. So it all starts with the history. We have you as a patient fill out a 17-page questionnaire. One of the pages has like 40 questions on it relative specific to peripheral neuropathy. And so from that, we get a pretty good idea. Does this look like you have peripheral neuropathy, or do you might not have peripheral neuropathy? Case in point, if you're a 21-year-old female and you have numbness and tingling in your feet, immediately I'm not thinking that you have peripheral neuropathy. I'm thinking that you have MS. Okay. But that's the importance of the history. Okay.
Now, I must say, Doug Gates came into this after we had started into this direction. When he first came in, I've had other gentlemen come in, other doctors came in who wanted to help out and help develop these procedures. And they said, and the first thing I would say to him is, well, I said, you need to understand something. The examination, or the history and the examination is going to be our calling card. You're going to have to learn how to do a history examination. He was the first one who ever went like, all right. I was like, ooh, maybe we have something here. Boy, do we have something here. So the history is ginormous. I want to make a point on this history. Again, I've been in this since '79, which means I went to school in chiropractic college, which, by the way, is probably the best placed profession for having developed this, because we got 400 hours of diagnosis. Because even back then, we were taught nutrition. We had a very wide background, and we obviously do musculoskeletal work. We work with the spine and the brain, and well, most people don't realize we work with the brain. We work with the spine, the nervous system. So we're the only ones who really had the full background to really attack this. And back then, we didn't have MRIs, and we didn't have CAT scans, and nerve conduction velocities were basically torture in their inception. So we were taught to take an hour-long history. If I was in the clinic and I walked out of a room in 45 minutes, I mean, my clinic director would be going like, you didn't take a good history. I was like, I took a good history. Like, no, you didn't take a good history. Go back in there, that type of thing. And nothing has changed. We were expected to come up with a diagnosis within 2 or 3 what they used to call differential diagnoses, with a history and an exam. And interestingly enough, that's more or less what we've had to go back to today. As you know, you're going into doctor's offices and you're getting a 7, and I'm not cutting your doctors now, okay? This is just what they are forced to do now. None of them want to do this.
By insurance companies, and we address that fully in chapter 2.
Yeah, none of them want to do this. We have doctor friends, they are not happy campers. But so in 7 minutes, I can tell you, they're not going to figure out your peripheral neuropathy. We couldn't figure out your peripheral neuropathy in 7 minutes, and we know what we're looking for. So we had to go back to kind of old school. But to go back to doing, we have a 17-page history that we have morphed down from a 40-page history years ago, and a very thorough exam, which Dr. Gates will delineate. We both do the exam, but on the peripheral neuropathy cases, Dr. Gates' part of the exam is really probably 80% of what needs to be done to figure out what's going on. And so this is what you have to do to figure out what's peripheral neuropathy.
Exactly. So just as you said, I mean, immediately what I'm thinking is, okay, is there any potential that the lower back is causing this? There's very specific patterns in the history for lower back issues. You stand up and your lower back hurts and your feet go numb, or you sit down and your feet go numb. That's less characteristic for neuropathy, more characteristic for low back.
Right.
Do you have just pain?
But people who aren't skilled
right.
in musculoskeletal work, like chiropractors, are missing that whole piece to your diagnostic puzzle.
They might be. We're just saying we're very well positioned to be attentive to that.
No, I said the people who don't have a back.
Gotcha. Yeah.
I didn't say it. Yeah, sorry. We try to be careful not to.
We do.
To guide people. I wasn't being.
Then we argue half the time.
More than half the time.
Because we want to be very specific, and just as you said, we're not denigrating anybody. So anyways, and then we're looking at, is it a tarsal tunnel syndrome? Is it that nerve in your ankle? Do you have excessively pronated feet? Is that simply the cause? Or does it actually look like neuropathy? And then we got to get into the nitty gritty of it. Do you have diabetes? If you don't, then we start digging, because the history is really where the rubber meets the road, because we're not going to run $10,000 in lab testing just hoping to find the cause of the 80 other causes of your neuropathy.
The history takes that 50 or 80 different causes from there, and it kind of brings it down to here.
Right,
down
exactly.
to 2, 3, 4.
And then we have a pretty good idea at that point what is resulting in the neuropathy, and then we go from there.
And then the exam should correlate with what we see in history. And then usually by that time, and the reason I cut it at that point in time is where you now don't have to do all those tests, because you know exactly what tests you need to do, because through the history of the exam, you have built the box. Okay, well, it could be this. Oh, it's not that. Oh, it's not that. Oh, it's not that. Oh, it could be this. Now you have your box when you're done, and you go, this is what we're going to test for. And it results in very efficient testing procedures that give us data that is useful in getting that person better. So the testing that you would do in this paradigm would be not to try to figure out what's wrong with somebody. You're kind of confirming what you've already figured out, but it's really more or less at this point to try to figure out how to get rid of this.
Right, exactly. Very true. And so then that delves more into the functional medicine side of things. So then again, if we think that this is a B12 deficient neuropathy and you match that pattern of it, then we're going to start digging for those causes of the B12 deficient neuropathy.
And you did mention beforehand, electrodiagnostic testing is part of our procedure. We don't do it on.
We don't do it on everybody, but we do refer people out for it when it's needed. And you have to know that not all neurologists are trained in electrodiagnostic testing, so lots of times you may go and they'll have neuropathy, or sometimes they really like to do electrodiagnostic testing. It's fine either way, but we try to use your dollars and your insurance company's dollars to the greatest effect. And then also, you mentioned we've seen cases where they've had an electrodiagnostic test and they do have neuropathy, and that really goes into small fiber neuropathy, which is this new, it's not a new area, but relative to prediabetes, it's very new. And so basically, no criticism intended, but I've run into neurologists who weren't even aware that prediabetes causes small fiber neuropathy. And small fiber neuropathy is where the little nerves, think of your sciatic nerve as being a bundle of cables. Some of the cables in that bundle are really big, and some of the cables are really small. And the really small ones encode pain and temperature. So lots of times small fiber neuropathy patients have burning pain at night. The bed sheets hurt their feet. Their feet turn red and blue, and it's just a miserable condition. Well, in the last 10 years, and it's really gained traction since about 2010, most of the research came out of the University of Utah in their neurology department, where they've shown that prediabetes is significant enough to damage the small fiber nerves, and then that can lead to a person having a normal electrodiagnostic test, because the electrodiagnostic test is testing the big cables in the bundle that I described as an analogy. And it will miss the small fiber pathology.
And a really properly executed exam procedure. When we're talking about examination, we're talking about you being in an exam room and one or the other of us, both of us are involved in the exam, examining you hands-on and doing, I mean, basically you have your clothes on, and you're put through a number of procedures neurologically and physically. We do a general systems exam, and that examination will tell us if an MRI is necessary, or if a CAT scan is necessary, or if an electrodiagnostic test is necessary. And I would say we frankly don't do them probably 80% of the time because the examination is so forthcoming in what is wrong with the patient. But if there is any signs in your neurology that it looks like there might be something going on in your spinal cord or your brain or something like that, that examination would tell. And I say that because a lot of people ask me that in the consultations.
Yeah.
So the first thing is to make sure that you have peripheral neuropathy, and it can be done. And it can be done with great clarity if an examination is performed, and if it's performed thoroughly by someone who understands how to interpret the findings. And it's very rare that at the end of that exam that we will not know what is probably going on. So then the next thing for you is to get any testing done. If it needs to be testing, if it's negative, if it's positive, you would go in that direction. There's a number of different things that we want to go over. Now, I keep talking about this 50 to 80, and so obviously we're not going to go over all that in an hour. But there are probably 10 or 12 or 15 things that keep coming up over and over and over and over again. That like one of these situations, like an autoimmune problem, may be being generated by something going on in your gut, and by taking care of your gut and calming down your immune system, that may address 30 of those potential different causes. So we're not going to go over all 80, but we're going to go through some of the major things here that you really need to know if you're running around with peripheral neuropathy. And is there an order you want to do this?
Let's just go down that list.
You want to go we'll start with nutrition and gastrointestinal disorders, because one of the things we have found out here is in most chronic conditions, peripheral neuropathy being one of the ones we treat the most, the gut, which means the large intestines, the small intestines, the liver, the stomach, the pancreas, the gallbladder that's missing in so many of our patients, is kind of where the rubber meets the road as far as fixing the physiology that's creating this problem. So what would you like to think we should discuss specifically?
So we know that certain vitamin deficiencies result in neuropathy, but then we have to, the easy way to step back is to say, well, maybe you're not absorbing the vitamins. So that causes us to look at a lot of things that we've mentioned. Celiac disease, that's an autoimmune disease to gluten. So if you eat wheat in the form of breads, pasta, cereals, salad dressing, your immune system can attack that gluten. That can create inflammation in your gut, and you may not be absorbing minerals and vitamins as well as you should. Same thing goes for Crohn's disease and ulcerative colitis. Those are what are termed inflammatory bowel diseases, where the immune system is inflamed against the small intestines or the colon, and they can result in malabsorption as well. Now, specific to the vitamins, we have thiamine deficiency. Thiamine deficiency can also occur due to alcoholism. So we've had quite a few alcoholic neuropathy cases coming in where people are just heavy drinkers. Maybe they've gone through rehab now, they're turning their life around, yet they've developed this pain, tingling, numbness in their feet, secondary to all those years of chronic alcohol consumption. It can be due to two mechanisms. One can be just malnourishment because they were drinking so much, and therefore they develop a thiamine deficiency. It's also being shown that the alcoholics who are well nourished, who are eating a lot while they're drinking, can still have neuropathy secondary to the alcohol exposure.
And these things damage your nerves, which, as you have educated me on, are the most sensitive tissues in the body. And actually, I always thought it was the thyroid, but because of certain things that we see, but they damage your nerves, and so you have to reverse that situation relative to the thiamine deficiency, and you have to stimulate the nerves. And the point want to draw through all of this is peripheral neuropathy is generally presented to you as either diabetes or we don't know what it is. Okay, Dr. Gates already indicated that even if you have pre-diabetes, what's happening there is it's being missed because it's not out there yet into the medical community that pre-diabetes also causes peripheral neuropathy. However, peripheral neuropathy is a multi-systems problem. I sometimes use the term complexity, but it is complex, but it's multi-systems. For example, I mentioned before that people have fibromyalgia, 50% of them have peripheral neuropathy. Just to give you a quick example, years ago, I got pneumonia. I was under a lot of stress. The next thing you know, I wasn't recovering. My energy never came back. I put on weight. My whole body started to hurt, and my feet started hurting and get numb. And I thought it was because I was skiing at the time, and I thought I put my boots on too tight. But in the end, I developed celiac, a gut problem. We're talking about gastrointestinal problems here. I developed celiac, which caused, and I didn't know it, so I'm still eating. Celiac, for those of you who don't know, is in the end, for lack of a better term, you eat gluten, it damages your gut, and it creates a lot of bad things, right? And so it damages the gut. Next thing you know, I'm feeling all these different other symptoms, and so it was all connected. It all developed at once. The cascade of what happened, I'm not going to go into right now, but the bottom line was that it was pneumonia. Next thing you know, I developed an autoimmune problem. It's called celiac. That immune problem actually ended up tagging my thyroid. Both of those contributed, and my stress at the time. But all three of those contributed to me developing this fibromyalgia and peripheral neuropathy. So kind of keep in mind that scenario as we're talking, that because what I experience when patients come in is they're looking for the next, I'm going to use that term, the next thing. They're looking for the next thing. They're looking for that next supplement or the new drug, and it's not like that. When Dr. Gates talked in the beginning and he said, well, you're going to have to change your lifestyle and you're going to have to do all, I said, what he was saying was the medical model still is looking for the new bullet. It's not going to be there. It can't be there, and you'll know that after you listen to the rest of this, because there are so many systems involved. You have to get the worst system better first, and then as that system gets better, other things get better, and then you have to find the next system, and this is how it goes. And the gastrointestinal, I'm making a point here because the GI system, if you have any gut problems whatsoever, whether you have them or not, we're looking at your gut. But if you have any whatsoever, I can guarantee you that in some way, shape, or form, they are contributing to your peripheral neuropathy. The next thing you want to talk about was autoimmune and connective tissue.
Right, and I just want to do one more thing on gluten.
Oh, yeah.
So gluten is a huge issue in neuropathy.
Okay.
So now it's actually, 5 years ago, we read a lot of neurologist reports.
Now, gluten's controversial.
Gluten's controversial.
Not here.
Oh my God,
Not
gluten is so
controversial.
controversial. I'll just say 5 years ago, I didn't see one test for gluten in a neuropathy patient. However, now I'm seeing it because it's more acknowledged in the neurology literature, because a seminal study came out, I think it was 2006, where they demonstrated that upwards of 1/3 of idiopathic peripheral neuropathy cases have a gluten intolerance. Actually, excuse me, I think it was 1/3 of all neuropathy cases.
You said that's what you told me.
Yeah, 1/3 of all neuropathy cases. So a very, very high percentage, especially for all of you who are told that it's not diabetes, we don't know what the heck is wrong with you. And what they're finding is that just as when some patients eat gluten and it can kill the gastrointestinal tract, as in your case, that immune inflammation can get overreactive and start killing the nerves down in the feet. And then the interesting thing is they've done studies where then they take patients with gluten intolerant neuropathies off of gluten, and typically they don't feel better, but their nerves tend to function a little better based on electrodiagnostic testing. So that is the data on gluten, but it's important for all of you who don't have a diagnosis out there. Something to look into and talk to your neurologist about. Then we have autoimmune issues. So 1 in 6 now, the upward estimate, in this American country have an autoimmune disorder. Autoimmune disorders can range from autoimmune thyroid disease to MS to celiac disease to ulcerative colitis. It goes on and on and on. Just rheumatoid arthritis are the biggies, lupus, Sjogren's. And so if you have an autoimmune disorder diagnosed by your internist or your rheumatologist or your endocrinologist, understand that if you have peripheral neuropathy as well, that autoimmune disorder may be doing the same thing as we exemplified with gluten. So your immune system may be so overreactive that's also leading to inflammation of the nerves, causing the nerves to die and degenerate. So, and then after that,
next thing would be medications, past and present.
Oh, yeah.
And this gentleman came in yesterday, he had kidney failure. I was surprised. He's a pretty bullheaded guy, and he really has done his best to handle his situation. He's just about to go into kidney failure. They're looking for a kidney for him, and you would never know it to look at. But he was only on 4 drugs. Was going to be my point. And usually someone like him walks in, I was like on 15 medications. But there's a certain point where medications can be part of the problem.
Absolutely.
And you list a number of them. When I'm doing a talk on peripheral neuropathy in a couple of days, and this is our research and development department. So I'm continually going, okay, what did you find this week? So I mean, some of them are real obvious, like the statins, but you want to go through the major ones?
Yeah, absolutely.
Yeah.
So
there are certain medications that may be contributing or causing your specific type of peripheral neuropathy.
let's go with statins first, because everybody loves statins with neuropathy. So basically, statins are a very controversial topic relative to this.
3rd largest selling drug in the country.
Yes, so many people out there are taking them, and it is a very emotional and discussion lots of times between alternative practitioners and medical doctors. It doesn't need to be that way. But basically, medical doctors feel they're protecting you by putting you on a statin because it's going to lower your risk of heart disease and things of that nature. Lots of times, alternative practitioners look at it from the flip side and say, well, why is your cholesterol high? And namely, too, why don't we fix your diet so that your cholesterol is high? Some of you, yes, have genetically high cholesterol, but we have found it to be such that if we change your diet, lots of times cholesterol can go.
Oh, there are people who don't know statin drugs are for cholesterol.
Okay, so statin drugs are out there to do exactly that.
Even people coming in here are taking them.
Really?
Yeah.
Okay. So they're designed to lower your cholesterol so that you have a lower risk of heart attack, because when cholesterol is high, you have an increased probability of that cholesterol depositing into arteries, clogging arteries, therefore causing heart attacks, strokes, things of that nature. Now, a big article came out, I can bring it up for anybody who wants it, that demonstrated those taking statins have upwards of a 1,400% increased chance of developing peripheral neuropathy. That's astronomical. That's a 14 times increased chance. So we have seen many cases where a person was started onto statin medication, all of a sudden they develop peripheral neuropathy. The thought process there is that if they're on a statin, it decreases the other fats that are needed for nerve function, and that can be possibly deleterious or negative to nerve function overall, especially relative to peripheral neuropathy.
It's so common that there's one group in the country that handles peripheral neuropathy only by getting you off of statins and then doing the electrical stimulation, which, as you'll see, is somewhat limited, but it's pretty common.
Yeah, we find it to be pretty common, and we're not like out there, we're not zealots about this issue.
No.
We work frequently. I have to take an hour off and go over to the hospital, and I work with a cardiologist, a couple cardiologists over there, where we do trial stimulations.
We work with internists
on patients who have pacemakers, because you're not supposed to do electrical stimulation on a pacemaker patient unless you go and see the cardiologist and make sure it's safe. It's not interfered with their device. And some of those patients, they need to be on a statin because they're a medical train wreck. And that's just the fact of the matter. And so just know that it's not right or wrong either way. There's a middle ground. But this
if
is
you're on a
part
statin
of
drug, if you started taking a statin drug and within weeks or months you develop peripheral neuropathy, just know in our history we're thinking that may be a problem, and we work with the medical community to address that.
And so statins are the big one. Other ones include those of you treated for tuberculosis. There's a drug called isoniazid that can deplete your body of vitamin B6. Interestingly, jumping back to nutritional deficient neuropathies, a lot of people with neuropathy take neuropathy support formulas that have a lot of B6 in them. And we've seen cases of B6 toxicity, which causes a neuropathy that is very severe. And we even saw a case that we couldn't help after the B6 neuropathy had set in. Jumping back to medications, another one is Flagyl. Flagyl is commonly used for things like diverticulitis, some irritable bowel syndrome cases, some parasites. Problem is, if you take Flagyl for a long period of time, we had a case where she was taking it for 2 years, it can cause a disabling peripheral neuropathy as well. Other medications include amiodarone, colchicine for you gout patients. The list goes on and on, but you kind of have an idea that there are quite a few medications that are associated with that.
So
not including
if a person comes in
chemotherapy.
here, we look at the whole list of medications and factor that in. Again, history means something. If you've been told, well, it's either diabetes or we don't know what it is, I hope you're getting the idea that it's a little bit more involved in that. And we're taking 78% of all the prescription drugs in the world, in this country. So it's fair to look at the medications in almost any chronic pain or disease. And then there's cancer, and then there's chemotherapy.
So the thing with cancer is that we always ask, have you had cancer before?
Mm-hmm.
Because you may have had breast cancer 4 years before, and you think that's in remission. And sometimes the cancer can manifest itself early on with the immune system trying to kill the cancer, and those immune cells can cross-react to the nerves. And so you may be presenting with numbness in many areas of your body, and really it's due to your immune system trying to kill the cancer. So that's A, that we try to look at. B is, if you had cancer and you took chemotherapy and your neuropathy set in after that, that's called chemotherapy-induced peripheral neuropathy. We've seen many of them. Some responded, let me say it this way, many of them responded, some have not. And basically, the toxicity of those chemicals designed to kill the cancer are also toxic to the nerves. They can cause vitamin depletion, things of that nature. And yeah, and as we alluded to before, someone called just say that the neuropathy is worse than the cancer. I don't know if I agree with that. And we have a case going right now, sweet lady, where they weren't going to do any more chemo on her because her neuropathy had set in. I wrote a letter to her doctor saying, really her neuropathy is really improving. So if you need to treat her, you need to have this data that I'm working with, that she's getting better, because don't let the neuropathy be the thing that's holding you back.
Okay. Right. And again, even if a person came in and they had that cancer presentation, you have a history of cancer and you have these pains all over the place, that would trigger go into the box, and that would trigger testing for that. So we're not just doing global testing for everything, history, exam. Oh, you had a history of cancer, this showed up around the same time, after that same time. Or I had this show up and then I was diagnosed with cancer, or whatever, then that's going to be investigated if that doctor hasn't already investigated it. And then genetics can play a role in you getting peripheral neuropathy.
And basically, the genetic neuropathies on a whole tend to cause pronounced muscle weakness. There are a few exceptions, but typically the genetic neuropathies are under the umbrella of Charcot-Marie Tooth disease. There are many different subtypes of this. But in essence, it presents with you having atrophy in the legs. Commonly, Charcot-Marie Tooth patients are
your
even
muscles
aware.
start to shrink.
Yeah, they're not even.
If you're looking down and your calves start to get smaller, that's atrophy of the muscles in your legs.
And you may have difficulty like standing up on your toes or going up on your heels. Many times, though, Charcot-Marie Tooth patients aren't even aware that there's numbness down there. It's not until we examine it, say, wow, I can't really feel anything down there.
Right.
But the muscle weakness is the most pronounced finding. So that's Charcot-Marie Tooth. Now, we have worked with Charcot-Marie Tooth, and we've made the ones that we've worked with, we said, in our estimation, the weakness is not the main thing we're going for. Most likely, we're just trying to improve sensation and balance. And we have had a few successes with that, which was pretty cool.
Yeah. And again, we try to evaluate ahead of time as to whether we should put that patient through our protocol. What is the patient's chances of recovery, so that when, we're not, for the most part, we don't have patients that go through a program and not get better. And go, okay, kind of sorry. But we do have patients that we may suggest that this may not be a good program for them. So again, and I'm just going back to history exam, we will treat patients the first day as a part of our examination and evaluative procedure. We will utilize these stimulations to determine whether that patient's neurology seems like it will respond to the types of things we're doing or not. And so it gives us a pretty clear picture as to whether we should go forward with that patient. Now, the next one is kind of my big blind spot. A lot of what Dr. Dace is talking about is like, partially was my job at one time, which is not anymore, but that's okay. And but monoclonal gammopathies of
Uncertain
significance.
That's a mouthful. So,
and one that I'm not really that conversant with, but fortunately, he is.
So with monoclonal gammopathies of uncertain significance, let's call it MGUS. Basically, 10% of idiopathic neuropathy is due to MGUS. So it's significant. That's a big chunk of you out there. So we have to evaluate you for it. And in essence, it's where your immune system gets overactive and starts making immune cells, typically directed at the nerves down in the feet. Now, there are many nuances to this. Monoclonal MGUS, usually presents very similar to a type of bone cancer from a lab perspective. So we will run these specific lab panels on neuropathy patients where we suspect this. They're basically bone cancer panels. And if it comes back and the person, will make sure the person doesn't have bone cancer either, then it looks like they have this thing called the MGUS, which can cause neuropathy. The interesting thing about MGUS, from our perspective, we've treated basically, let me be conservative. I believe we've treated 7, but I'm going to say we've treated 6 patients with this. And 5 of the 6 had a very positive result. And as an example, there's only like one other, we should write this up. There's one other study out there where they had like a sample size of 13 and they were given a very powerful immune dampening medication and there were marginal improvements. So with that being said, the reason why we think our approach responds is that there's being shown a certain type of bacteria in the gut that is eliciting the immune system to try and kill that bacteria. Exactly. And then that's leading to this overactivation of the immune system to the nerves down there in the feet. And a lot of our focus is on the gut, changing the flora in your gut, so to speak, looking at food intolerances, healing the gut barrier. And we can presume that that is why we're seeing such phenomenal results with these cases.
We do get a lot. We do get a lot of people coming from out there, and in my interview and in my intake, I'm talking to them. So you have any digestive bowel problems? Like, yeah, like, so. But
Right.
like, so.
How's that related?
Like, I got news for you, pal. You got a gut problem, we don't fix it. You're probably not getting a long-term response from what we do. And so now to the well-known.
Yes.
Now this is a good one too, because now we're going to talk a little bit about diabetes. We got 3 or 4 more we're going to go over here, and then we're going to kind of cut it at that because we will have covered, and I think giving you an idea of what your battle is, what you're up against, and when you're walking into somebody's office and you're asking them, well, I got bad feet. You know, you go to the podiatrist's office and they say, oh, you got peripheral neuropathy, and I'm going to give you Neuron or whatever. You know, which, as those of you who are watching this, if you have peripheral neuropathy, you know, eventually that doesn't eventually work either. And we'll get into that a little bit. The diabetes. Let's talk about diabetes. Now, I'll tell you, but what I get is people come in, they either have diabetes, and it's usually diabetes type 2, and they've gotten on the diet, and they've lost the weight, and they still have peripheral neuropathy. Or they have diabetes type 2, they're on 2 medications, they're telling me how much better their blood numbers are because they're down to 135, which is way too high. So in my case, I have to look at that person and say, no, your 2 medications are not working, which means there are other problems involved, and those problems are usually problems that are contributing to your peripheral neuropathy. Or you have somebody who is really taking care of themselves and they look good and still they can't lose weight, they still have peripheral neuropathy. We have a bunch of variety.
Oh, yeah.
We have a variety of presentations from the diabetic patients. And I don't know if you want to dip back into the fact that the pre-diabetes patients, in essence, they should change, in my opinion, they should change the numbers. They should just say, once you're over 100, you have blood sugar problems, as opposed to saying, oh, you got pre-diabetes, you got metabolic syndrome, and we're not going to treat you until you got diabetes type 2, and blah, 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 blah.
I can agree more. Yeah, absolutely. So yeah, so with that, half of neuropathy cases are due to diabetes. Then,
pretty much, if you have burning in your feet at night, there's a good chance you have blood sugar.
Yes, yeah, pre-diabetes or diabetes. And typically pre-diabetes causes more of the burning symptoms. And then they're showing that with idiopathic peripheral neuropathy, this pre-diabetic small fiber neuropathy may be accounting for a much larger percentage than we ever thought.
We see a lot of it.
We do see a lot.
Like a lot of it.
And again, this is a relatively new phenomena. Diabetes is diagnosed as when your blood sugar is over 125.
3 times in a row.
3 times in a row. And then your 3-month measure of blood sugar is over 6.4. 6.4%. It's called the hemoglobin A1C. Prediabetes is diagnosed as a person having a fasting blood sugar over 100, and then also a HbA1c over at 6 or above. And then also with prediabetes, they talk about the oral glucose tolerance test more frequently than they do with diabetes, which is where you chug 7,500 grams of glucose, and then they track to see what your sugar is over 2 hours. And if it doesn't come below a certain point, then you have prediabetes. Or if it's way high, it's diabetes. That's how you diagnose it. But the commonality with all of these that we have found is that if you can get the blood sugar down to where it should be, and then go in and rehab the nerves, we've seen some phenomenal results. Now you're probably saying, like Dr. Rutherford alluded to, I'm watching my diet and my blood sugar is still up. What's going on? Well,
maybe you got a bad gut.
Exactly.
Oh, here we are, back in that gut again. These guys are like gut nuts. They can't get their brains off the gut. That was a huge
Maybe that's our next book.
Gut nuts. Hey, that's good. But that was a huge breakthrough for us. We've had several breakthroughs along the way. We finally figured out the gut had to go first.
Oh yeah.
That
Everything fell
into place. Huge breakthrough for us.
And what we're finding,
and getting consistently successful results.
Again, this is the newest of the newest data. And so we just came onto this in 2013. And we're even sending this information out to other internists, diabetes specialists, because they need to be aware of this too. It was talked about extensively at this conference we went to, but everybody at this conference is trying to be up on the latest and latest studies.
A couple weeks ago.
Yeah. In fact, Dr. Rutherford and I were laughing because this one lady presented a study. I said, oh, that's so November. But that's where you have to be if you're going to try and work with these issues. So what we're seeing relative to diabetes is that there can be excessive absorption of pieces of bacteria, not bacteria themselves, pieces of bacteria. And those pieces of bacteria, they're termed LPS. Remember that because I'm going to lipopolysaccharide. And that LPS.
They probably didn't know that.
Lipopolysaccharide.
They probably don't know what a lipopolysaccharide.
I just want you to know LPS. LPS is like a finger on a bacteria. They're like fingers on bacteria, and they break off and they can go into our bloodstream. If there's way too many of them, we can get toxic shock syndrome, like the lye tampon incident in the 1980s. That was due to pieces of tampon getting lodged in the reproductive tract of females, and then bacteria growing on them. Those bacteria had LPS endings on them, and that LPS went throughout the body and caused all these women to get really sick and some of them to die. This is happening at a lower level in diabetics. They're calling it subclinical endotoxemia, which is where just too many of these LPS things are in their bloodstream of people who are obese, pre-diabetic, and diabetic. And they're showing that this LPS directly causes insulin resistance and is directly associated with obesity, directly associated with the liver. Yeah. Exactly. And so we have totally centered our world on figuring out the right diet for the person, but also working on probabilities for this LPS issue and decreasing the probability of these LPS growing bacteria in the gut, also decreasing the absorption of those. So just so you know, the fatty cheeseburger and french fries, you're going to absorb a lot more LPS than if you're eating a salad, most likely. That's what the literature is showing too. And then we work on barrier integrity, where we're going in, we're trying to shore up the intestines so that less LPS is absorbed.
Now, if we got too much of it, it can directly damage your nerves. If you don't have, or what happens is it creates the insulin resistance, or it creates the diabetes type 2. Those of you who are out there who are walking and eating right and and still have diabetes type 2, and if you have diabetes type 2 and you're taking a medication and you're doing all that, you probably have this. And then this ends up causing the peripheral neuropathy.
Exactly.
Okay.
And so many people in this book just wrote, the diabetes chapter is 30 pages long right now. And I detail, well, how could this person who was on this diet before had these blood sugar numbers on these medications, and all of a sudden they go into our program and now their insulin is cut in half, which we have had happen. A lot. Yeah. And so what we're seeing is that even if you're on insulin, lots of times you're insulin resistant too. That can happen. So by correcting this mechanism, the insulin resistance can go down. You may need less insulin. Your blood sugar can be under better control, facilitating what we're going to do with your diabetes. And if you're not insulin dependent, then it's going to be even easier.
Yeah. And if your blood sugar is consistently over 100, I would just, in my mind, wipe everything out that you've heard about metabolic syndrome, syndrome X, prediabetes, insulin resistance, diabetes, just know you have a blood sugar problem. And one of the things that we're talking about is causing it. And that's what happened. And why is that important again? Because blood sugar, at least diabetes, is acknowledged as causing half of the peripheral neuropathy in this country. And frankly, even the people who have blood sugar issues, it's usually part of what's causing it. It's not the only thing, but it certainly is something that needs to be addressed if you have it. And there's just a lot of people not even looking at that as the cause, because their doctors are still saying, you're 115, we'll wait until you get to 125 and then we'll treat you for your, there are some doctors who are using preemptive metformin at 110 or 115. The problem with that is we'll go back to the drugs that can cause peripheral neuropathy.
Metformin can cause B12 deficiency. So
metformin can cause a B12 deficiency, which can cause peripheral neuropathy. So again, I'm just trying to draw out the understanding of the different systems that are involved, the complexities of how one system affects another. You give somebody metformin to get their blood sugar down, their blood sugar is not coming down, and then all of a sudden they got a B12 deficiency, and it's affecting their feet, and everybody's going, what happened? That's what happened.
Exactly.
Infections.
So HIV can cause neuropathy. We have seen those cases.
Yeah.
Hepatitis can cause neuropathy. Lyme disease can cause neuropathy. Obviously, there can be mononeuropathies like shingles, exacerbations, things of that nature.
Obviously.
Yeah.
Wasn't that obvious?
But anyways, those infections can cause.
So they have to be evaluated, and they're evaluated. Okay, you do the history. We have a bunch of questions in the history to indicate there might be infections. So that's why it's this is why it's a 17-page history. Okay, and organ failures. We had one yesterday.
Kidney failure, liver failure, critical illness. So if you've been really sick, you're in the hospital, ICU for like weeks on end, you can develop peripheral neuropathy. Lots of times I think it's because you're not getting enough oxygen in your body, you're very sick, there's a lot of toxins in you, and that can result in neuropathy.
Right. And the last one we're going to cover is hormones, because everybody wants to know about hormones. Everything's hormones in this country. We got a hormone replacement center everywhere. Like every 5 miles, it's like hormone replacement therapy. So hormones.
Hormones, thyroid is the most commonly acknowledged. Basically, hypothyroidism untreated can cause the nerves to slow down in their function, resulting in neuropathy. Hyperthyroidism can actually do the same thing. Less commonly acknowledged, but it can result in neuropathy. I think most people are aware of thyroid. So if your thyroid is low, you tend to be sluggish, you tend to gain weight, you tend to be fatigued, you tend to lose the other third of your eyebrows, you may be balding, you may get, kind of a puffy face, puffy legs, constipated, hoarse voice, so on and so forth. If you have hyperthyroidism, you're jittery and shaky, you look like, who's that comedian with Roger Clark with the eyes? How do you his eyes?
Feldman.
Was it Feldman? Okay, so Feldman, where you get the eyes coming out of your head, your hands are shaking, you have diarrhea, your blood pressure is like 130 over
Heart palpitations.
70, heart palpitations.
You're getting heart palpitations, and you've gone to the doctor a bunch of times, and they go like, everything's normal.
Yeah,
you think stress or think thyroid.
Yeah.
Think hyperthyroid.
And then with thyroid disorders, most commonly in today's society, it's not an iodine deficiency, it's an autoimmune issue where the immune system is killing the thyroid. It's referred to as autoimmune thyroid disease. If you're hypo, it's generally termed Hashimoto's thyroiditis. If you're hyper, it's generally termed Graves' disease. There are mixes of those two, but we don't need to go into that.
And again, I go back to me. I got pneumonia. It set off an overwhelming infection. What ultimately happened was it set off an autoimmune attack against my gut, and an autoimmune attack against my thyroid
and your performance.
And then ultimately that affected my peripheral nerves, and then I ended up with peripheral neuropathy. All of which I hope you can understand. I'm feeling pretty good today. I'd say I'm 95% better at all of that. And it's important enough. The thyroid part is important enough that I think there's going to be a whole chapter.
There is a chapter
relative to thyroid in the book. So again, we want to draw the understanding to you that it's a complex issue. It doesn't fit the current model of care of walking into somebody's office, getting a quick kind of like 5, 6, 7 minutes. Oh, doc, my feet are burning, they're aching. They're okay. Maybe you got peripheral neuropathy. Let me send you over to get a electrodiagnostic test. The electrodiagnostic test maybe says you're normal. and you're going like, what the heck's going on? Like I can hardly walk, I'm losing my balance, my feet feel like rocks or whatever. And it's just that our system is moving away from the types of histories and the types of examination procedures that are needed. All of this is, did you attach anything to the?
Yeah, I attached the articles on Neurology.
Okay, so there's like 20 articles attached to this. If you were to watch any of your other presentations, I mean, there's everything we talk about is in the literature. There's a neuropathy series that comes out. Is it every year, every 4 years or something like that?
Yeah, every 4 years.
Okay, so it comes out, and it's done by the medical profession, and all of this is in there.
Okay.
All of this is in there, but it's not being used because it doesn't fit the present model of care. Insurance-wise, that I must say is going to continue to narrow a person's ability to get a proper workup for peripheral neuropathy and for a lot of the things that we treat. And so that's really, and I'm not saying it to like criticize. That is just the facts, and I'm saying it so that you understand why, this is your battle. This is the first part of your battle, because if you just run into somebody who says, you have it, you got to live with it. Here's Neurontin, here's Cymbalta, here's Savella, whatever they're using on you, or whatever combination you're using. Eventually, that's not a good trade-off. It may help for a while, but that's not a long-term solution. It doesn't cure. It doesn't heal the tissues. It doesn't stop the downward decline. And that's the model. That's the model that you're presented with. There are other things out there, and there are other things that are successful. So I think that pretty much covers it.
That pretty much covers it. So if you have any other questions, you can send them to us at powerhealthtalk.com. You can send them to our Facebook page. We'll try to answer your questions as best as we can. Just know we do consultations with people. If you're in another state and you have questions, we can do that too. And yeah, we'll go from there. Thank you for watching.
Yeah, I hope this was helpful, and please send us your questions if you have any. We'd be happy to help you out.
And hopefully this will be coming out soon. It's not just a bunch of pages.
June,
it's all there.
for sure.
By June.
June, for sure.
All right. Thank you for watching.
All right.